But this is a webinar series, as I think you know, and just for the audience, many of the folks will have been to prior webinars, but just as a quick introduction, this is the last of this year's webinar in our K12 Neurosurgery Research Career Development, or NRCDP program. I'm one of the co-PIs of that program, along with Langston Holly, who I see online. I think he's with us. Our main PI, Greg Zipfel, I think will be joining shortly, along with our fourth co-PI, which is Ahmad Eskandar. And the goal of the webinar series that's kind of along with this NRCDP program is really try and put information out there for folks who are looking to launch or advance their careers as neurosurgeon scientists, really at any career stage. But the NRCDP, the K12 program itself, is really focused on early faculty. But the webinar series is set up so that we can disseminate information that could be useful even for students, residents, early faculty, or even more advanced faculty. And we've saved the best for last of this year's webinar series. I'm really, really pleased that we're able to have Louise McCullough with us tonight. She is really a world-renowned stroke neurologist who is really known for her work as a physician scientist, as a mentor. We were just discussing, if you jumped on early enough in this webinar, how she's worked not just with neurologists, but even neurosurgeons in that capacity, and has a very well-recognized cadre of work that relates to sex differences in stroke and sex and gender disparities. She's had an incredible influence on the field in that regard. She's been involved with NIH, implementing some of the things NIH has put forth over time in terms of the requirements to be thinking about sex as a biological variable and inclusion of not just male animals in basic and translational research. And she extends really across that basic translational and clinical research realm. She's got a lot of accolades. I won't take up the time going through all of those, but really has been received many of the highest awards from organizations like the American Heart Association, recognizing not just her scientific work, but also her mentorship. And so hopefully we can glean from you, Louise, a bit about your work in regards to the specific scientific topic. But as you kindly offered too, if there are questions that relate to launching of early careers and strategies on how to do that, she's really a perfect person to pick her brain as well. So we'll let you get started. And perhaps if folks want to unmute or put questions in the chat as we go, I'll try to monitor that, and we may interrupt you as you go along, Louise, if things come up in the moment.
Absolutely. And if it's boring and it's not like you're like, oh my God, why am I sitting through this? Feel free to unmute and ask questions completely off topic, and we don't even have to get through the slides. Okay, so thank you for the introduction. And I have mentored a lot of Ks, including neurosurgeons, helping them with that transition to their R01, as well as the K12 program for pediatric neurologists. We actually just received one of those last week for one of my mentees who's looking at neonatal hypoxic ischemia. So first of all, I wanted to make sure that you guys understood the difference between sex and gender. Mostly if you write a grant about this, you want to be very clear that you know the difference. So gender is only applied to humans. It is a societal construct, as if you see yourself as male or female or feminine or masculine. So you don't say gender when you're talking about cells, cultures, animals, okay? Sex is the biological result of the interplay between sex chromosomes and gonadal hormones, because those are the primary driving differences between males and females. We all learned back in med school, back in the day, that women have two X chromosomes, men have an XY, but that second X chromosome doesn't do anything, right? It gets all wrapped up, becomes the bar body for genetic balancing. Well, it turns out over the past decade or 2 decades, we've realized that is not true. About 20% of genes on the second X chromosome are are transcribed and translated, and X chromosome inactivation can be leaky. So women may have double copies of certain genes, and a lot of very important pro-inflammatory genes are on the second X chromosome. And what we think is happening is with menopause and waning of estrogen, that allows transcriptional de-repression of some of these genes. So it gets super complicated. So I won't get too much into the genetics. So as far as clinical goes, women remain underrepresented in clinical trials, and that's true of endovascular trials, stroke trials, cardiac trials. Often we don't use female animals, and people will say, oh, well, we'll just look at males first and then we'll look at females. A lot of times you don't know the sex of your cultured cells or your organoids, and that actually becomes very important. This is going to be very important for those of you applying for grants now, because this is a scorable criteria. So you have to address that you are either using only one sex and why. So if you're studying prostate cancer, you're good. If you're studying glioblastoma, not good. You have to look at, if you're doing glioma models in the lab, for example, not only should you report what glioma model you're using, what sex is the glioma model, but what sex is the animal that you're putting this glioma model into. A lot of the excuses why people don't use them is they're like, oh, it's too expensive. We have to double the amount of animals. Oh, the hormones confuse everything. And oh, well, we're going to find these same biological mechanisms, whether it's male or female. Well, that's not true. And all you have to do is look at a man and look at a woman and recognize they have different chromosomes, different hormones. We have different organs. So it's not really surprising that sex differences are everywhere. And if you look for them, you're going to find them. So this is some very early work we did back way when I was in Hopkins, and I had really struggled to get my first grant because I was convinced that there were sex differences that were important. And these sex differences were found not just in animals, but in cells. So this first panel just shows that if you take male neurons and female neurons from embryos and expose them to oxygen glucose deprivation, which is really stroke in a dish, that the male cells were ischemic sensitive. So you can easily figure out what sex your cells are. So if you're using a cell line, super easy. You just do genotyping for this gene called the SRY gene. The SRY gene is the gene that makes you male. It is on the Y chromosome. So if you inherit a Y chromosome, you inherit the SRY. That is the testes determining gene. So if you inherit a Y, you inherit the SRY, you develop testes, and you secrete testosterone, and you become phenotypically male. We have the myog gene is a gene found in everyone. So you can see these are the males here, and with the SRY gene. We have lots of animal models, which I won't get into, where we've actually taken the SRY gene off the Y chromosome and put it on an autosome, chromosome 3. And that way we can make all these wacky genetic models where we have XX males and XY females. So the XX males inherit the SRY on an autosome, so they develop testes and become phenotypically male, but they have two X chromosomes. XY minus the SRY phenotypically develop into females, secrete estrogen. So a way to manipulate and differentiate chromosome and hormonal effects. So this is some of our very early work showing that this actually matters, and it matters in models of ischemia. So this is just hippocampal slices. And you can see here, this is a male control, this is a female control. These are hippocampal slices, and this is basal 24 hours and maximum cell death. So these are controls that are not given OGD. So you can see here, there's a little bit of this little bright signal. This is propitium iodide, which stains dying cells. And then we kill everything in the dish, and you can say, okay, this is 100% cell death, and here's the females. So you can kill them all off. But if you expose males to OGD, you can see in this hippocampus a huge amount of cell death. And when you calculate that from the maximum cell death, you can see a lot of these cells are dying. And again, just like we found in neurons, we see the females exposed to OGD for the same amount of time don't have the same degree of cell death. Importantly, if we give drugs that inhibit certain pathways in cell death, they benefit one sex and not the other. So it probably becomes very translationally relevant. How are we doing in the clinical realm about reporting of sex differences? We're still doing pretty crummy. We are improving. 2023 showed about 43% are now reporting outcomes by sex, and this is really driven a lot by the editors of these journals. But you can see we really didn't budge at all, that a lot of these studies didn't even include sex in the analysis or didn't even report sex differences. So we've come a long way since 2015, which is when we really made a concerted effort on the NIH side to at least report this data. So talking about stroke, I'm a stroke neurologist. You want to know, are there sex differences in these models of stroke? Now, ICH with a hypertensive hemorrhage, we don't really know that much about this. We do know that females, women, especially if they're older, are more likely to go to palliative care earlier. We know in subarachnoid hemorrhage and aneurysmal subarachnoid hemorrhage that women are about 60 to 65% are women, especially women postmenopausal. This is the model we study in the laboratory. So here's a CT showing a pretty extensive left MCA infarct. And the reason we study this one is because there's very prominent sex differences, subarachnoid as well. I think they're in the ICH, but we just haven't explored it quite as much. But we study this model because the vast majority in the US of strokes are ischemic. So this will be another kind of teaching moment. Go where the money is, okay? So there will be money coming into the sex difference bucket. So it is a good area to get interested in because there's going to be an additional bolus of funding to look at some of the sex differences. So just epidemiologically, 1 in 5 women will have a stroke in her life versus 1 in 6 men. So over the lifespan, women are disproportionately affected by stroke. But in most age groups, stroke is more prevalent in men than in women, but things really change as women age. And since women live longer than men, they have a higher degree of stroke burden. So stroke is the 3rd leading cause of death in men or in women and the 5th leading cause of death in men. So things change a lot with age, and I won't talk too much about it today, but we really think some of that hormones during the lifespan of women, when we lose those hormones with menopause, that women have much more pro-inflammatory microglia. They have a very different immune response to stroke, and that becomes very noticeable after menopause. More women die after their stroke. They're more likely to be disabled. They're more likely to need nursing home placement, but they also have higher rates of secondary stroke, depression, and they're often socially isolated, which is an area we study in the lab that I'm not going to talk about today. But social isolation is a huge driver for disease, whether it's mortality from cancer or mortality from stroke. And it probably is because it induces a lot of basal inflammation. And we see that in animal models. So it's not just non-compliance or you can't get to the store or you live alone and you're lonely and you're drinking and you're smoking. We can model this in C57 animals. If you take these 2 genetically identical mice and you separate them for 2 weeks and give them an induced stroke, their stroke is 50% bigger if they're isolated. So isolation is very detrimental. And women are more likely to be isolated because they've often outlived their spouses. But age really matters. Doesn't matter to me. The patient in front of me is a woman or a man. But the reason women do so much more poorly after stroke is multifactorial. And most of it is driven by the advanced age that women experience their first stroke. And here's a meta-analysis of about 15,000 patients, and there's recent data kind of recapitulating this, that if you don't adjust for factors like age or pre-stroke function, women are 35% more likely to be dead after a stroke in 1 year. But if you adjust for things like age, stroke size, and premorbid status, then basically this goes away. So some of the factors that are really driving the increased mortality in women are age. There are these social factors, they're post-stroke depression. And women also have higher NIH stroke scales, and they have more LVOs. And that's probably driven by the higher rates of cardioembolic strokes seen in women. And this has been known for a long time. This is old data, and this is the stroke etiology in men and in women and in men. And you can see women have a much higher frequency of cardioembolic stroke compared to men. And again, that's because of their older age. They may be having more AFib. They may not have symptoms from AFib. They may be under anticoagulated because we think they're frail and they're going to fall. You have to fall like 300 times to make up the morbidity of a left MCA stroke. So just because someone is frail or older does not mean that you should not anticoagulate them. And this is probably why we see more LVOs in women. Women are also less likely to be routed to a comprehensive stroke center when they have a stroke. So it's kind of a double whammy for women. We know that women in AFib, again, this is old data, and this is why the CHADS-VAS2 scoring for risk of an embolic stroke in AFib gives you a point just for being female, because we know that women, when they are in AFib, whether they are anticoagulated or not, have a higher rate of cardioembolism. And it's really striking as you get older. So what is it that's different about a woman's atria or left atrial appendage? Could it have more fibrosis? Could it be procoagulation factors? But we have known for years that women have more cardioembolic strokes, whether or not they're anticoagulated. So something's going on in the heart, and that's another area we study in the lab. And this is reflected by the CHADS-VAS2 scoring risk, because it incorporates sex and that known increased risk in females by giving you a point. So it's really important to screen older patients, especially older women, for AFib. If you see a cortical stroke and they're not in AFib, you should really think about putting in an implantable cardiac monitor. It takes like 10 minutes. It will monitor them for 3 to 4 years. And the average time to detection from stroke to the detection of AFib is 81 days. So if you send that person out with a 30-day Holter monitor, you're just, making yourself feel better, because average is probably closer to 3 months until you pick up that AFib. So have a low index of putting in these implantable monitors. They're very low morbidity to put these in. So speaking about what Seppi was talking a little bit in the beginning, back in 1993 is when the NIH said, okay, we are not including women at all. And everybody was worried about pregnancy. You never want to enroll a pregnant woman in your trial, right? So in 1993, they said, okay, we require the inclusion of women in clinical research. That was 1993. It wasn't like 1920, which is always amazing to me. And still, inclusion of women is not required at phase 1 or 2 of NIH-funded subject trials, which is a big deal because these are the healthy volunteers. And this was one of the issues with Ambien, which is now comes in a pink bottle and a blue bottle of sex-specific dosing, because they found that women that were taking Ambien for sleep were having a lot more car accidents, and they were falling asleep, and we were overdosing them. 80% of the drugs taken off the market in the late 90s, and this is still continued into the 2000s, had adverse effects in women. And it's probably because of dosing or metabolism. Now, back in 2015-14, we really started thinking about how this matters for preclinical studies. So now you have to include a statement about sex as a biological variable in your grant. It is a scorable criteria. So whether you're doing clinical or preclinical research, you must have a section about sex and gender. So don't forget to do that. Okay. And is it important? And do we care? Again, going back to this reporting, this is the trial that changed our guidelines for blood pressure management. We all say, okay, lower blood pressure is good. So this is intensive blood pressure lowering for cardiovascular events of a blood pressure of 120/80. And what you can see here that changed our guidelines in the New England Journal of Medicine, here's the data. So the box size of the box tells you how many people were enrolled. So you can see a lot more men were enrolled in this trial. Now, if you know anything about stats, this is the confidence interval. And you can see both men and women had a benefit from lowering the blood pressure. But in women, because they were under-enrolled, this confidence interval crosses 1. Statistically not significant. So am I doing a really good thing taking my 85-year-old lady and driving her blood pressure down to 110? Or am I going to make her orthostatic fall and break a hip? So when you see this, really we have to start thinking about using adaptive trial design. If you see that you're over-enrolling one sex or the other, we probably should have said, okay, let's continue to enroll women so we can tighten up this confidence interval, and that will make me feel a lot more confident that really driving down blood pressure is good for women and men, which of course it is, but I would feel a little more confident if that's what the data showed. And does it matter for drug treatment? Here's a trial of patients with cardiomyopathy with preserved ejection fraction, heart failure with preserved ejection fraction, which is more common in women. And they enrolled equal numbers of men and women, as shown by the size of the box, but this drug had absolutely no effect in men, and it had a significant benefit in women. So if you didn't do this sex-specific analysis, you'd be like, yeah, maybe we should use this drug. And you're going to be exposing a lot of men to a drug with side effects that has no benefit. This is the importance of reporting by both sexes. And we're still doing it. So here's a little sneak peek of some very recent trials, the Optimus trial, which just came out like a month ago in the Lancet. So these are pretty good journals. This is when do we restart anticoagulation when we have a stroke patient. We've always said, okay, minor stroke, a couple days, moderate stroke, maybe a week, oh, a huge stroke, maybe it should be 2 weeks. There's no guidelines. So that's where these trials came into play. And the Optimus was just reported, and like the other 2 trials that have been reported for this, all show that earlier treatment with anticoagulation with a DOAC is superior and prevents recurrent ischemic events. So we're probably waiting a little too long to start our stroke patients with AFib back on anticoagulation. About 40% of these people didn't have known anticoagulation before their stroke, but we should be starting that Eliquis a little bit earlier. And speaking of Eliquis, another thing that I see clinically is that people are overdosing their elderly women. So Eliquis is 5 milligrams BID. Unless your creatinine is greater than 1.5, unless you're greater than 80, or your weight is 60 kilograms or less. If you meet 2 of those 3 criteria, you should be on the 2.5 milligram dose, not the 5 milligram dose. So who's likely to be over 80 and under 60 kilograms? Women. So be very careful with your little frail elderly women. Make sure that if they're over 80 and their weight is 57 kilograms, they should be on the lower dose. So anyway, these trials have all reported, oh, look, early start is better. Okay, early start is better, prevention, no increase in ICH. And here's what is buried on page 67 of the supplement of this trial. You can see here, here's females, here's males. Nobody was harmed by early anticoagulation, but in both of these trials, the benefit of early restart was driven by females. You can see the incident rate here, 6.3%. Versus 11.3% for a delayed start. So these women were much less likely to have another stroke if they were started early. Men, it didn't seem to matter at all, which is fine, right? But here in the females, again, 2.7 versus 5.4. So you are really benefiting women for starting anticoagulation early. And that's probably because they have more thromboembolic events. Okay, all right, now we're going to move a little into the lab. This is the model we use in the lab. This is a kind of typical, we have lots of models in the lab, but this is kind of our go-to model because it kind of reflects what we see happen in thrombectomy with reperfusion. So we put a suture up the ECA, feed it up to the bifurcation of the middle cerebral artery, and then with a silicone tip, we block off this MCA here. And you can see on this India ink stain, here's the MCA infarct. You can see the ACA in this particular mouse is pretty vascularized, but you can see this area of infarct. And this is the way the infarct progresses in a mouse. Even if you reperfuse, and we see this also in patients, like even if they reperfuse, they can still have bad outcome. This is 1.5 hours after the stroke. This is a coronal section of a mouse brain, and everything pink is viable tissue. This is a dye called TTC that is picked up by mitochondria and converted to pink. So the white area is the area of stroke. So 6 hours, you're seeing a striatal stroke, and then by 12 hours, kind of a patchy stroke through the entire MCA. And by 24 hours, the stroke is pretty much histologically complete. There is a lot of stuff going on in this brain, but histologically, the damage is kind of done by 24 hours. This becomes important in a later slide. So basically, histologically, stroke complete, 24 hours. Lots of immune changes in here, and can we still salvage tissue and improve outcomes at 3 days or 7 days? The answer is yes. It's kind of not a bad model of an MCA stroke. Okay, so is it important in preclinical models to care about sex differences? So here's just one example. This is a hemispheric infarct of males, and this is an IgG control drug, and this is the drug. And the drug is not a secret. It is tocilizumab, which is now going into clinical trial for ischemic stroke. It's already shown benefit in cardiovascular trials for MI. Tocilizumab, you may be familiar with it, is used for giant cell arteritis now and rheumatoid arthritis. It is an IL-6 receptor inhibitor. You can't block IL-6 with an antibody because you just make more IL-6. What you want to block is its soluble receptor, which is floating around in the plasma and brain. And here you can see tocilizumab significantly reduced infarct 3 days after stroke. And this was a sustained effect that we saw even a month after stroke, that we saw a significant reduction in the brain atrophy. In females, there was no significant effect. So we're like, oh, okay, maybe, we were dosing it wrong. We were dosed based on weight. So what a very smart grad student did in the lab is said, well, if it's soluble IL-6, that receptor is getting shedded. Maybe there's different levels of soluble IL-6. And this is mice. And here you can see in sham mice, there's really no sex difference in soluble IL-6 receptor levels. But after stroke, females have a major increase in this receptor. And this tocilizumab is what quenches this receptor. And here in stroke patients, again, no difference in controls, but in stroke patients, 24 hours after stroke in their blood, females had women had a much higher level of soluble IL-6 receptor. So we probably weren't quenching signaling. So we went back to the lab and said, okay, well, let's increase the dose and see if we can quench this soluble IL-6 receptor. And the answer is yes. In males, we saw that neuroprotective effect, and there was no additional effect to increasing the dose. But in females, there was no effect with the low dose and a significant effect of the high dose. And we found this was directly correlated with the soluble IL-6 receptor levels. Well, this is important if you're going to do a trial of tocilizumab, right? Do we need to be doing a bedside ELISA? Do we need to be doing sex-specific dosing? Those are going to be important questions for that trial. The other big biological factor, which is going a little off the sex story, is aging. We know that most people with stroke are older. They're over 65. You see, an increase in maternal stroke, but what are we modeling? Are we modeling stroke in this nice, healthy, plump 32-year-old? are we modeling this in this person with vascular dementia? This patient actually is one of my patients that has cerebral amyloid. You could drive a truck through these Sylvian fissures, lots of atrophy. So we said, okay, why are we modeling stroke in 12-week-old animals in the lab? These are 3-month-old, so they're equivalent to a 12-year-old, like, not that many 12, 15, 20-year-old strokes. So we said, all right, we got to model stroke in aged animals. And very surprisingly, and this was recapitulated in SPAN and recapitulated by numerous other labs now, which is not at all what we expected, because all of our aged animals after stroke were dying. When we first started, it was like an 80% mortality. All the aged mice died. So we did a lot with animal husbandry. We also did confirm this with MRI. The young strokes had huge strokes. The young animals had big edematous, big strokes. And yet a week later, they're scampering around the cage, and you've got to do put adhesive tape on their paw to try and get at some mild deficits from the stroke. They're missing half their hemisphere and they're just fine. Age mice had a significantly smaller stroke, but they had significantly worse neurological deficits, higher mortality, and their deficits never went away. And in fact, they got worse over time. So we said, all right, what's going on? So we looked at these aged mice, and like I said, when we first started, everything was dying. So we said, we looked at these mice and we noted that they were getting a little hypothermic. And they looked like they were getting septic. So we're like, oh, well, they're all dying of sepsis. And we all know that in stroke patients, one of the biggest drivers of mortality is infection. So we looked at IL-6, kind of your go-to pro-inflammatory cytokine. And you see in the young stroke mice, they have a big peak after stroke in their IL-6 levels. But they clear that by 24 hours, they're almost back to baseline. Aged mice never clear that inflammation. Even 30 days later, they still have an increase in IL-6. They also had features of immune suppression based on the lymphocyte to myeloid ratio. So our animals looked like they were getting septic. So we took the organs of these young and aged stroke mice and we ground them up and we put them on, this just happens to be a blood agar plate. We've done it anaerobically and aerobically. And you can see these little white dots here. These are colony forming units. These are bacteria. And you can see compared to the young stroke, despite this stroke animal having a much bigger stroke, the aged animals were riddled with bacteria in their lungs, in their livers, in their everywhere. So we found that these colony forming units were significantly higher, suggesting a greater systemic bacterial burden in the aged animals. But is this because, and this was really driven by stroke, but even at baseline, aged animals had more CFUs. So what we did is we then took these, swept them up, and sent them for 16S sequencing. What are these bacterial colonies? Where are they coming from? And when we looked at them, of the bacterial colonies that we were finding in young animals and aged animals were really different. And a lot of them were gut derived. They were from the gut. And this has also been shown in humans now, that even humans with like pneumonias, a lot of the bacteria that's seeding the lungs are not from oral flora, they are from gut flora. So here you can see what happens within 12 hours after stroke. And this is, now we've confirmed this also happens in people. You give a brain injury, a sterile brain injury, the gut does not like it. It is no bueno. So there is some systemic or vagal connection between the brain and the gut. So here's a fish stain. This is the fish here. This is bacteria, this red stuff. This black area is the mucus barrier. The mucus is what protects us from all the bacteria in our gut, and this is host. And you can see what happens in stroke. In stroke, all of a sudden, you get disruption of the gut epithelium, you lose the mucus barrier, and you can see these bacteria just creeping in to the host. And those are the bacteria that we were finding on those blood agar plates. So what were these bacteria? they were the gut microbiome. This is stuff that we did about 15 years ago, but now the gut microbiome is uber hot. So and it's actually, we're doing a project now with Joshua Esquenazi, who's one of our neurosurgeons here with glioma, looking at how the gut microbiome changes with chemotherapy and with resection. But the gut microbiome is the community of microorganisms, which includes fungus, bacteria, and viruses. So we're focused on the bacteria, but the viruses and fungi are probably also very important, that exist in a particular environment. It's initially colonized at birth by your mother. I'll tell you why that's important later. So it's inherent, you're born pretty sterile. There really is not a amniotic biome, right? Children are born, neonates are born relatively sterile. They're colonized by their mother's biome. These microorganisms are super dynamic. They can change in days with antibiotics, with diet, with stress. But probably what's more important than the bacteria themselves is the metabolites they produce. Some of these bacteria make metabolites that we as mammals cannot make. They can be helpful, commensal, or they can be pathogenic. We've shown now that the biome changes with age, and we get a lot more dysbiosis or detrimental shifts in the biome to these more gram-negative, angry, pathogenic bacteria. And we've shown this with PCA plots. Here's a young microbiome, here's an age microbiome. They don't overlap. And this is in animals that are in the same mouse house, eating the same chow, housed together. So this is pretty fundamental feature of aging. So there's also got to be a host factor that allows this more detrimental biome to take hold in our gut and flourish. But basically, the best way to look at this in a snapshot is called the F to B ratio. So in young animals, you have a lot more of these bacteroides and fewer of these firmicutes, which are pretty negative bacteria and can cause LPS and activate toll-like receptors and cause a lot of host inflammation. So in a young biome, you have a lot more bacteroides than firmicutes, and that shifts in an old biome, and this is true in both animals and humans. So a snapshot of dysbiosis is this F to B ratio. So the F to B ratio, if it's low, you can see in young animals it's low. In aged animals, you start getting more of those firmicutes. So what we first did in some of our initial studies is we said, okay, well, can we change the biome and change stroke outcome? And you can see in a young donor, they don't have dysbiosis. If we give an aged donor to that young mouse, so everything about that mouse is young except its biome, we recapitulate the dysbiosis. If we give an aged recipient young donor, we can rejuvenate the biome. So does that matter for stroke? Of course it does. So when I told you about all that high mortality, we took young mice and gave them a fecal transplant of aged microbiome, and see what happened? Almost none of our young mice after stroke died. They're very resilient. Just by having an aged biome, the survival dropped to 50%. We had to stop this study because we were killing all the young mice. Nothing else different about them except they have an aged biome. So what we wanted to do, because stroke is an unpredictable event, we had first shown that if we reconstitute a young biome before a stroke, that we made stroke outcomes much better in aged mice. But we don't know when a stroke's going to occur. And if this is going to be therapeutically useful, can we alter the biome after stroke and improve outcomes? So that was our goal in this study. All of the animals were aged. So they're 18 to 20-month-old mice. So that's like a 65, 70-year-old person. We gave them a stroke. And remember, I told you the stroke is histologically mature by 24 hours. So we gave them a stroke. We waited 24 hours, and then we gave them antibiotics. We had appropriate controls to clear the host biome. And then we gave a fecal transplant gavage of either aged or young donor biome. So all the animals are aged. They get a stroke. They get a fecal transplant of either young or aged biome. And you see the aged mice that got the young biome had much better regain of their pre-stroke body weight. They moved more in an open field. They had better cognition on a novel object recognition, and they had less behavioral depressive phenotypes. So when we look at the gut, because we know the gut is acting, these are both aged gut, and this looks like an aged gut. They don't have good mucosal barrier. There's a lot of inflammation here. They don't have good goblet cells. This is also an aged gut. This gut looks great. You can see this mucus layer, nice goblet cells, very good crypt architecture, and this is still an aged mouse. The only difference was they got a young fecal transfer after their stroke. So we saw more goblet cells, we saw better mucus, and we saw lower gut permeability in the aged animals that got a young microbiome, meaning the gut barrier was more stable, so those detrimental bacteria couldn't get out. So the animals were not getting septic. And again, as I mentioned, probably more important than the bacteria themselves are the metabolites that they produce. One of the key metabolites are short-chain fatty acids. These are end products of fermentation of dietary fibers, probably part of the reason the Mediterranean and high-fiber diets are so good. This gives the bacteria something to eat to produce these more healthful metabolites, such as short-chain fatty acids, which we know enhance the gut barrier, they reduce the risk of inflammatory diseases, and they are lost with aging. They can have very potent anti-inflammatory effects on microglia, and those are probably more important than the bacterial composition. Now, fecal transplants are kind of gross, and you're also transplanting those fungi and those viruses. So what we wanted to do is say, well, if short-chain fatty acids are important, can we then give short-chain fatty acids instead of giving a whole fecal transplant? So here you can see the short-chain fatty acids, much higher prevalent in a young biome than an aged biome. And then we basically gave the same study design. We gave aged mice, but instead of giving a fecal transplant, we gave a cocktail of short-chain fatty acid producing bacteria and inulin, which is the substrate that they use to make these short-chain fatty acids. And we were able to increase the levels of short-chain fatty acids in the gut, in the blood, and the brain by giving this bacterial cocktail of very defined bacteria instead of giving a messy fecal transplant. And this was actually even better than the fecal transplant. The ones given the probiotic and the prebiotic had almost no neurological deficits. And these animals had a stroke 3 days before. And so really, really profound effects. So we said, okay, well, could this be important in our patients? So we have a large biobank here, and you can see these are the short chain fatty acids on metabolomics in non-stroke patients, hot, they have a lot of them. And look at what happens in stroke patients. 24 hours after stroke, they have almost no short chain fatty acids. So is it an opportunity to either give bacteria or to give the short chain fatty acids back and prevent this drop in short chain fatty acids in stroke patients? Possibly. So this is where we'll go next with a clinical trial. I wanted to really briefly, and I'll go through this lightning fast because I want to make sure you have time for questions, but an area of interest of mine is the stroke risk that's associated with pregnancy. We know that women are actually holding off childbirth for career reasons, whatever, but your stroke risk doubles if you're over the age of 35. Most of the stroke related to pregnancy is related to hypertensive disorders of pregnancy, like eclampsia or preeclampsia. We are doing a really bad job in the US. The maternal mortality ratio is more than double of the next top high-income countries. But more importantly, I think, is things that occur during pregnancy can have an effect both on the offspring or the fetus and the mother. We know that a history of preeclampsia increases the later risk of both hypertension, stroke, and vascular dementia in both the mother and the offspring when the offspring ages. So you can see this big increase in death if you're having a pregnancy 40 or over, and this is increasing over time. And this decade is the first decade more women have had children in their 30s than in their 20s. And this is leading to an increase in mortality. Japan is one of the hardest hit countries, and you can see the mortality just skyrockets as the woman has a pregnancy when they're older. And as mentioned, a lot of this is driven by hemorrhagic stroke. So unlike the other epidemiology I showed you, pregnancy-related stroke is really driven by ICH, is more common than ischemic stroke. And again, these are studies showing in cohort studies that if the mother has preeclampsia, eclampsia, hypertensive disorder of pregnancy, that it increases the hazard ratio in the offspring by 1.7. So if your mother had preeclampsia, you are more likely to develop high blood pressure. And it is not seen in your sibling who was born of the same mom who didn't have a hypertensive disorder in that pregnancy. And what's really interesting is in Denmark and things where you can follow these people forever is they also had a higher risk of vascular dementia when the women reached their 70s and 80s, and it wasn't Alzheimer's disease, it was vascular dementia. So tying together our microbiome work and our dysbiosis and this maternal thing, we decided, hey, why not model this in animals? So what we did is we took young female mice and we gave them a fecal transplant of either young female biome, middle-aged female biome, or age biome before we bred them, before they got pregnant. Because remember, I told you, your biome is seeded by your mother's biome. So simply giving a young mouse an aged biome, we saw a significant loss in fecundity. We saw a lot of stillbirths. You can see some fetal remnants here in the uterine horns. So the number of unborn pups in this young female that had an aged biome was much higher. The pups per litter was reduced, so fertility was reduced, fecundity was reduced, and the pups that were born low birth weight. Importantly, the pups, we then let them grow up to 2 months and then to middle age. And these pups had a depressive phenotype that persisted out to middle age. So this one thing you do to this mother during pregnancy changed their behavioral phenotype, and it also changed all their brain and plasma inflammatory markers. So you can see, even at 10 months of age, the animals, the pups that got the biome seeded from this dysbiotic mom had alterations in brain and serum inflammatory markers. They also had changes in their neurotransmitters, which I'm not showing. One thing I just wanted to really quickly mention is if you get called for a consult on a pregnant patient, these are the things you have to think about. But I really wanted to stress 2 things that you should not miss. 20% of preeclampsia and eclampsia can occur postpartum. So in medical school, we always learn, what's the treatment for preeclampsia? Deliver the baby. Well, a lot of people don't have features of preeclampsia until after delivery. So here's an example, and this was a lawsuit. This is a 38-year-old woman with her second pregnancy, had no problems with the first pregnancy. She comes in, oh, look, her blood pressure is great. Her blood pressure is great. Even when she's delivering, her blood pressure is great. And then this is her last blood pressure right before she's discharged. This woman needs to go home on a blood pressure cuff because this is what she came back with 5 days later. This woman is now dead. You can see she has a very large hemorrhage. Her blood pressure was 220 and she had postpartum eclampsia, and she did not do well. So just be aware that if you see creeping blood pressures, even after delivery, your risk of these hypertensive disorders is not over. I just wanted to show this case because this was a miss. This is a 39-year-old postpartum headache. She has 5-day history of headache and numbness, progressive left arm numbness. So 5 days, she's postpartum 2 weeks. So she's kind of getting out of that postpartum eclampsia risk, which usually occurs in the first week. And she's got a progressive kind of picture. She has some worsening of headache in the morning, as well as some blurred vision. Anybody have any ideas what she has? High risk postpartum. When you deliver a baby, there's lots of blood. You got to coagulate. She has some features of increased intracranial pressure with headache in the morning. This is a cerebral vein thrombosis. Many occur postpartum. So do not miss this. Always get the MRV. And then this was a tricky case. This is a 26-year-old who presented with acute hemiplegia and aphasia. She delivered 3 weeks ago. She didn't have any hypertensive disorders. So 3 weeks, again, we're kind of getting out of that window of risk. But this kind of looks like the first patient, right? A big hemorrhage. But if you're careful, you look down here and you see this hypodensity and then the bleed. This is a cerebral vein thrombosis of the vein of Lebet. And here you can see another case here. So this woman had a massive hemorrhage. This is the only time you're going to give heparin with a bolus, because if you don't get this vein open, they're going to have progressive symptoms. And this is her MRV. You can see the transverse sinus here filling with contrast, nothing filling over here, and because it's got this massive clot in here. You can give heparin all day long. It's not going to get through this clot. If there's no channel, this is when you need to think about endovascular intervention. Okay, so just to conclude, women are disproportionately affected by stroke. They remain very underrepresented in clinical trials, and that is especially notable in stroke trials. And a lot of that is because in past stroke trials, we excluded people who were over 80 or had a modified Rankin of 2 or greater. Well, you've just excluded 40% of women with stroke. Age and stroke lead to significant dysbiosis and pathological shifts in the microbiome. Super important to model the disease in the appropriate animal model. In the case of stroke, I would argue that it's an aged animal. And there's very unique periods of very high risk for women and their offspring, and really driven by hypertensive disorders. And just want to thank everybody in the lab who did most of this work. And that's it for the science part.
All right, Louise, thanks for that terrific talk, and also for kind of weaving in how you've progressed along the science journey and bringing these factors to bear. We don't have much time, but we'll extend maybe 5 minutes since we started a few minutes late, and just to make sure if there are questions, we can get to them. If anybody wants to unmute, I do think we have one question in the chat. I don't know
and you guys are also welcome to email me. My email is very easy to find on Google.
All right. I see there's a question in the chat from Jason. Are you still on, Jason? Do you want to unmute and
Yeah, I'm still here. This is, obviously you want to design the trials with accounting for, sex-based differences. But I was just wondering, when you were talking about some of the findings in the early part of your talk between, between sexes, I was wondering if there was any concern about finding, statistically different outcomes for male and female sexes when studies weren't designed around those. And just like, anyone else might report a secondary, variable or post hoc analysis as significant.
Oh yeah, it's a great question. And that's why we have to design the trials initially to consider this as a factor. And I think this will become a bigger and bigger issue. There are, examples in subarachnoid hemorrhage, for example, that some drugs work much better in women than men versus not. But I think it's a really good point, because if you don't design the trials appropriately, you may find spurious results. So that's why it's important to at least report them. Whether they're significant or not, report the number of women enrolled, report the number of men enrolled. If there is a statistical difference, well, it probably should be explored. It doesn't mean that every single study that we do has to, be designed with sex differences in mind. But I think really just reporting the sex differences, whether they're present or not, would really be helpful.
Thank you.
Louise, I got a sense in one of the things you said that one of the ways to try and kind of address that during trial recruitment is being, an adaptive design, right? And we don't think of that very much, but you're right. A lot of trials will have a lot of disparate enrollment.
Yes.
There are ways to deal with that,
There are
right?
ways to deal with it. And if you just recognize it and report it, then you won't under enroll. Like that sprint trial, I'm sure lowering blood pressure is good for both sexes. But, to be confident, you say, okay, we're under enrolling women. If you're doing interval analysis of your trial, you should say, oh, okay, we're under enrolling women. We need to enhance enrollment, just like we do for racial disparities. Like we will do 1.5 ratio to try and enroll more Hispanics, for example, because we know that they may be more likely to screen out or say no. So again, it's really keeping an eye on these interval steps in a trial just to make sure there's sex balance, because we can't ignore 50% of the population, which is kind of what we've done in the past.
All right. I see another in the chat. Greg, if you're on, you want to, Louise touched a little bit on this at the beginning of her talk, but if you want to ask your question, if you want to unmute, otherwise I can read it out.
Yeah, no, I mean, a really
Hey,
nice
Greg.
talk. Hey, sorry, I was a little late, so
Oh,
if I
no
missed something at
worries.
the beginning, but it seemed like a fair amount of what you were showing was the impact of gender on ischemic stroke outcome, both in preclinical models and clinical models. Just wondering what your thoughts are about in hemorrhagic disease, ICH, SAH, and then do you even have a sense, are the investigators in those spaces paying attention to the impact of sex as much as you and others seem to be doing with ischemic stroke? Just thoughts about that.
I think they're getting to it because they're being forced to, right? So ICH is kind of unknown. We do know that women are more likely to go palliative, especially if they're older. That's probably due to their older age and their comorbidities and their pre-stroke disability. But nobody's really looked at like hemorrhage at at the kind of very big level yet. Subarachnoid hemorrhage, there is no doubt that there is a sex difference. More women are affected. Women tend to have more DCI. They will have multiple aneurysms compared to men. And we know that is somehow linked to estrogen. We don't know exactly how, but it's very clear that subarachnoid hemorrhage from cerebral aneurysm rupture is a more female predominant disease. Again, it tends to occur after menopause, so it's possible that there is some estrogen related effect, especially, and it's probably an even bigger difference because we also know smoking has a huge effect on aneurysms, and more men smoke, yet more women have both more aneurysms and more subarachnoid hemorrhages from their aneurysms. Don't know why yet, but I think it's an area of growing interest, and people just need to recognize it and make sure that they're looking at it in their clinical trials.
Any other questions? I know the hour is getting late.
I have a question. Yeah. Hi, Seppi.
Hey.
Hey, thank you, Louise, for that great talk. Any comments about intersectionality between sex and those from underrepresented backgrounds? How does that play out? We see that kind of can be a double whammy in a lot of different levels and different studies and different things in society, across society. How does that play out in research, and how would you kind of summarize that?
Huge. And for basic and more translational, we can't really mimic race or ethnicity. But the best example is maternal mortality. It is twofold greater in a Black woman compared to a white woman. A lot of that is driven by hypertensive disorders, which are much more prevalent in Black women than white women. And people say, oh, there's all these other social determinants of health and, education, prenatal care. But it's important to recognize there's something biological as well, because a white woman with a high school education is still less likely to have a maternal adverse pregnancy outcome than than a Black woman with a college degree. So there's something that's beyond even social determinants of health that is really driving some of this intersectionality of race, gender. But women from underrepresented minorities are double whammy. Not only is sex not really emphasized, certainly race is not either. But there's certain biological factors as well, especially in this maternal mortality rate, that is not just access to care. There's something different that makes Black women more likely to have a hypertensive disorder and adverse pregnancy outcome.
Right.
Don't
Okay.
know what
Yeah,
it
thank
is.
you. Yeah,
You know?
no, interesting. It would be great if there was, more interest in funding this type of work.
And I think there will be. And like Seppi and I were talking at the very beginning of this talk, it was very exciting. I got to go to the White House last Wednesday. Dr. Biden has made this a very big emphasis in the last year of her campaign, that we are underfunding underrepresented minorities, especially and women. So the goal is to pour about $12 billion into a funding bucket that is outside of the NIH that will specifically focus on sex and gender research. And so it's a great time. There's lots of NOCs coming out, notifications of special interest. So if you have data, if it's an area of interest, it is a great time to think about getting funding in this area.
Yeah, fantastic. Well, thanks for sharing that.
Sure.
And thank you, Louise, for your willingness for people to reach out to you, especially as
Absolutely.
the announcements come out. I think you'd be a great resource if folks are
And
interested.
if I see those NOCs, I can send them to you so you can send them to the group. And
definitely,
because sometimes they're like buried into things, and a lot of stuff fits. They kept it super vague because they want people to come into this area. They want people to study this because we never have. 1993 is when we made them enroll women in trials. Come on. It's crazy.
All right. Well, with that, thank you again so much, Louise. We really appreciate your taking the time out, late at night and at the end of the year. But as I said, best for last. We really enjoyed it. And a lot of folks will get a chance to watch the recording as well. So thank you.
Fantastic.
Happy holidays.
Happy
And,
holidays, everybody. I hope you all get a little bit of a break.
all right. Take care.
Bye.
Bye-bye.